Good afternoon, everyone, and welcome to my Friday message. It's always nice to begin with good news. On February 18th, a 37-member team led by Drew Weissman at Penn and included 7 researchers in the Duke Vaccine Institute received the prestigious 2021 BIAL Award in Biomedicine. The award recognizes work published in the journal Nature in 2017. The group demonstrated the first in vivo effectiveness of an mRNA-based vaccine technology in Zika infection in both mice and in non-human primates. That technology, as you know, is now used in the Pfizer and Moderna vaccines to prevent COVID-19. Congratulations to these outstanding members of our Vaccine Institute. They demonstrate the best of collaborative science that makes a difference, a well-deserved recognition. Now let me share some COVID updates. Trends in cases, hospitalizations, and most recently deaths are all trending down in many areas of the country and in North Carolina. We have also seen a continuous drop in hospitalized patients in our own health system, although the number is still around 140. Our test positivity rate in Duke Health is down to around 9% from a high of over 40%. Unfortunately, the number of employees out on isolation due to COVID continues on a downward trajectory. On campus, we had our lowest numbers of positive cases by our surveillance program in months, with 86 students and 20 faculty and staff. Duke announced this week that at the beginning of the week of March 21st, required COVID surveillance testing for asymptomatic vaccinated students will end. Surveillance testing will continue at a limited number of sites across campus for unvaccinated students, as well as for unvaccinated staff and faculty who are required to test each week. Testing will also be available for those who wish to do so voluntarily. For students, faculty, and staff who are experiencing COVID symptoms, COVID testing will continue to be available through Duke Student Health or Employee and Occupational Health and Wellness. I want to take this opportunity to again thank the many members of our Duke community for all the work in implementing and continuously performing the surveillance program, recognized nationally for its innovative approach to provide massive, rapid COVID testing. In particular, thanks to the Duke Vaccine team led by Tom Denny for their leadership of the surveillance program. Also, thanks to our colleagues in student health and employee health for their continued extraordinary efforts to keep our community safe and healthy. Given the downward trends, many states and local communities are easing mask requirements. In fact, given the state trends, Governor Cooper encouraged schools and local governments to end their mask mandates and to continue to push for vaccination. But he did acknowledge that in some places, such as healthcare facilities, as well as long-term care facilities and transportation like airplanes and buses, masking should continue consistent with either federal regulations or what is best in the setting. The city of Durham has not changed its mask requirements for indoor settings at this time, but will continue to follow the metrics, including transmission and positivity rates, anticipating an update by the end of March. They are targeting a test positivity rate consistently, that means over 2 weeks, below 5%. This week was 5.7%, but the average over the last 2 weeks has been about 14. And a transmission rate less than 20 per 100,000, and we are at about 40 per 100,000. These metrics targets are based on the probability of continuous transmission. Duke is following Durham guidelines and will update our own guidelines as needed to align with the city requirements. Let me end with some important updates on vaccination. On February 11th, the FDA announced they would delay meeting to consider COVID-19 vaccination for infants and children under 5 years of age. This had been originally planned for last week. The pediatric protocol calls for a 3-part series, and only the data from 2 doses would have been available for that February review. Given the lower dose and the lower immune responses to the 2 doses, the FDA wanted to wait for additional information after the 3rd dose of the vaccine in that age group. It is anticipated that these results will be available for review in early April. I do want to take this opportunity to remind everyone that we still need to focus on getting those eligible for vaccination and booster fully vaccinated. This is especially true in light of the loosening of our infection control measures. For adolescents, a very important study came out this week in New England Journal of Medicine. This was a case control study of adolescents between the ages of 12 and 18 hospitalized with COVID in 23 states between May and October 2021. The data demonstrated that the overall effectiveness of the Pfizer vaccine against hospitalization was 94%. The effectiveness was 98% against ICU admission and 98% against COVID-19, resulting in receipt of life support. All 7 deaths occurred in patients who were unvaccinated. These findings are consistent with efficacy data from the original clinical trial involving adolescents between 12 and 15 years of age. Also of note this week, the CDC modified its dosing recommendations for Pfizer and Moderna vaccines, particularly pertinent to adolescents. It is still recommended that adults that are moderately or severely immunocompromised, adults over the age of 65, and others who need rapid protection due to increased concerns about transmission or risk of severe disease, follow the 3 to 4 week interval currently in the guidelines. The change is advising that it may be better to allow 8 weeks between the 2 shots for others, including adolescents. The CDC cited studies that showed a longer interval between the shots improved vaccine effectiveness, but also reduced the risk of a very rare side effect, heart inflammation or myocarditis, seen most often in young males. While absolute risk remains small, in fact, exponentially smaller than an adverse outcome from infection, the relative risk is higher for males ages 12 to 39, and this risk might be reduced by extending the interval between the first and second dose. There are currently no data available for children under the age of 12, and therefore an 8-week interval may be optimal for males ages 12 to 39 years. As always, a lot of information to share. I'll be back soon to provide more updates. Have a great weekend.